Good morning, good afternoon, good evening to everyone around the world. So it's our ACNS Young Neurosurgeons webinars again. So today's our chair is Professor Xinyu, who is the Deputy Chairman of the Neurosurgery of Tianjin Medical University General Hospital in Tianjin, China. He's also the Chairman of cerebrovascular disease surgery and also neurointerventional department of the Tianjin Medical University General Hospital in Tianjin, China. So we have two speakers today. The first speaker is Professor Erion, who is a developmental cancer biology of brain metastasis founder and CEO and partners in the healthcare clinic and foundation of the underserved communities in Albania. His topic today is genetics of aneurysms, a series of studies from the human to differences across the ethnic and geographical territories. And our second speaker is Dr. Farha Anjum, who is a neurosurgery resident in Clinicum Ingolstadt, in Ingolstadt, Germany. Her topic is Ultramicroneurosurgery. So for our discussion today, we have Dr. Sharon, who is a consultant neurosurgeon and KPJ Social Specialist Hospital and senior lecturer in Monash Medical University in Malaysia. And she's also our chair for the WIN chapters of the ACNS. And our second discussion is Professor Kimura, who is the Associate Professor of the Department of Neurosurgery of the Kobe University Graduate School of Medicine in Kobe in Japan. So at the end of the section, Professor Yang will also share a talk of the importance and balance of the surgeon between hardworking and patient care. So without further delay, shall I hand over the podium to our chair, Professor Yang?
Yes, thank you to Professor Kato and Professor Ben. You are hardworking, give us opportunity to learn from each other, and very happy to see all the friends and the Professor Erion and Professor Farha. And we have our motivator and discussants. All of you are welcome. And thank you very much for your hard work. And Ben, how about let's start from here?
I'm very, very thankful to Professor Kato and the Asian Congress of Neurological Surgeons for extending the invitation. I'm gonna present a work that it's still in progress. It's a collaborative work with colleagues from most likely across the globe, and I'm going to show you what we have done thus far. I know that most of you are clinicians who clip aneurysms, but we are changing the view and we want to see if we can treat aneurysms. So there are none on my end from disclosures. Back at the time when I was a postdoc research fellow at the Cranville Research Institute in Toronto and University of Toronto, I had the luck and the pleasure to work for a brilliant researcher and neurosurgeon, is Dr. Ivan Radovanovic, who has done tremendous work in the basic science of cerebrovascular disorders. He has mapped arteriovenous malformation and is currently collecting a large series of biological tissue from brain aneurysms. And it was then that I had some interest into seeing where the state of the art is in the aneurysms and the basic research science in the aneurysm diseases, or the disease process as we call it. I started reviewing originally Dr. Radovanovic's work, and then as I was moving on with the interest on the scientific work on aneurysm disorders, I stumbled on some great papers. And this is one of the seminal papers of the genetics of aneurysm diseases. Dr. Gunnell, a brilliant neurosurgeon who does open vascular surgery at Yale University, using an animal model, identified a gene that is involved in the development of aneurysms and eventually aneurysm rupture. But Dr. Gunnell used an animal model. Well, I sat down, it was around this time, about 2 years ago, and I wanted to review the entire work on the genetic and the basic science that has been published out there. And I realized that out of 400 something articles of interest, several patterns of studies developed as I was going through the search and screen of the articles. And I designed those patterns to be specific the way you see it here because they had different paths into the becoming a scientific group of works. When I was doing some rough notes, and I have some notes even showing the time that I was working on, I wanted to figure if we can design a path into orienting patients in the very near future, not only to clipping and to or coiling, but as well to medical treatment of aneurysms. I teamed up with a very good friend of mine. He's a brother to me. He's currently co-director of a skull-based lab in the Department of Neurosurgery. He's a brilliant vascular surgeon, a former fellow of Professor Lawton Reddy Rahmani. And I spoke with him and I said, Rezi, we have collected this very vast number of scientific work. What would you think if we put it together and create the patterns to publish it? And he was, as I was, enthusiastic at the beginning, and we said, okay, we need a team. And we started building this team of collaborators from around the world to put together what we were doing. And then we started realizing the patterns that emerged out of it. Out of many studies, we realized that most of the scientific work was based on animal models. On animal models, we realized that there were specific genes that we pulled and we extrapolated from that data that was responsible for the rupture of aneurysms. But on the other hand, there were studies done on animal models where there were development of an aneurysm, but there was no subarachnoidal hemorrhage, which led us to believe that there were genes that were responsible just for the growth of the aneurysm itself, but not for the bleeding of its rupture. And then somewhere in between, if you see the plots, there were biological processes where a gene, a specific gene, can have the potential to have the aneurysm grow and then eventually rupture. So it made it a little complicated to develop a general idea at the beginning, but we stayed focused on the pattern that we were developing. We wanted to identify signal pathways or molecules, or we wanted to check out if there was any pattern in the genes that we were identifying through the work that was already published that could come closer to a unique gene or group of genes that would tell us what specific pathways these genes or a specific gene was involved and what was the role. There were many of those that could not match, and some of those of specific pathways, for example, the calcium signaling pathway, which makes a smooth muscle around the aneurysm wall contract, was a popular hit around what we were doing. This is the same plot doing another work on the data that would tell us what would a specific gene do in the development of aneurysm. But at the same time, we realized that there were substantial differences on the work that was already published on the basic science of the aneurysm disease process across different ethnic groups. What that means is that the entire population of Japan does have a different pool of genes from that in Finland and from that in North America. And we wanted to see, other than the differences that develop or the interfere in the process of the development of the aneurysm, are there genes that are commonly shared across different ethnic groups? What we wanted to see in a different pattern when we were studying the genetics of aneurysm, wanted to see was what is different within an ethnic group and what is commonly shared across different ethnic groups around the globe. And the genes that we pulled from different ethnic groups paved the work onto identifying the positioning of these genes within the aneurysm wall, spread within the layers of the aneurysm from the intima all the way to the outer wall of the aneurysm, and their role for what the gene is known. And we created tables of these genes. As you can see, there are genes that are specific to a group, for example, in Asia, and then you see genes that are unique to people either in Northern America or Western Europe, which do not overlap across different ethnic groups. Does it make any sense scientifically? Well, are these genes new or acquired during the process of evolution and development of us as humans? We mapped it. We wanted to see where we stand. Unfortunately, the colored map shows the word that is published, but it doesn't provide an insight or the information for the rest of the world. Not because there are no aneurysms or the aneurysm disease process does not develop in Latin America or in Africa or the continental Australia, but just because there are no publications. So we thought we should map it and then provide it and make it available to the public, the pool of genes that have been identified, to make it available to the scientific community so they can add more data to the findings that we collected. And as you can see, even though the letters are, my apologies for that, small to read, there are substantial differences across the Asian continent, and then the Western Europe, and then the North America, which goes to show that there might be an evolutionary process in development of a disease as we know it, and we call it the aneurysms of the vasculature of the brain. Now, we mapped it and we wanted to see what are the differences, or is there any potential grouping if we use a CAG pathway? Unfortunately, there are not so many overlapping of the genes. What that means is that how many of these genes are present across different ethnic groups? Well, not so many, but enough to identify and start research work in some of those. And what their role is as well, which is labeled on the left of each of the tables. Another pattern that emerged is something of great interest, and we grouped it and we worked on that. We created another team working on it, is aneurysms develop in specifics within families. It's not only the aneurysms per se across individuals, but even within families that have a genetic patterns emerging differently from that we saw across different ethnic groups and individuals. So what we wanted to see is we collected and we pulled data from familial studies and twin studies. What that means is patients that are twins and they have the other sibling developed in an aneurysm, or within the family, parents and children, or within the same family, non-twin siblings. What is unique within the group of the patients developing aneurysms within the family, and what is different. And the differences, do these differences stay true across when we go outside the study and research of familiar studies? Well, in the work that we conducted, the data that we pulled and collected from the aneurysms within families, unfortunately no longer within twin studies because these were not statistically significant, we realized that there are common genetic findings on specific chromosomes that are specific to familial cases, but then there are unique genetic findings that belong only to the familiar studies that we cannot find across different ethnic groups across the globe, or what we call it within a specific case of a patient. What made us believe is that there is a genetic role that is transmissible within the family, within the genealogical tree of a family, and which is not acquired during the disease processes of aneurysm that develops in individuals. So in familial aneurysms, we mapped and we tabled all the genes that we could pull, and we tried to match with a function of relevance. And when was that published as well, which population or ethnic group it belonged. Once again, the ethnic group came to be important because some data was relevant. What that means is within the familiar aneurysms, there were genes that were particularly expressed in the ethnic group of the island of Japan. And then you'd find these genes that were totally different, but not present in the population of the continental French, but not islands of France. As well, the data extends to the Dutch population and the Colombian population, which inhabit North America, or the European ancestries in the North American continent. We wanted to plot all these and create tables for our interest, but as well to make it available to the public for reasons that I'll make it clear to you in the minutes to come. When we sat down and created common findings that we would see on the cellular components that make the disease process evolve within the aneurysms, we would identify from the data that was published 25 different genes that were unique to the cellular components. But then there were a small number, about 3, that was spread across not only within the familiar, but as well across disease processes of a human that are not member of familiar cases or twin studies, which makes us believe that not necessarily the disease comes through a transmissible mode under a genetic disease. What that means is that the bulk majority of cases that we see must be congenital. That is an acquiring mutation or a chromosome defect within the walls or the cells that make the mechanisms of the disease process of aneurysms where the disease forms. Another pattern that was of great interest for us, and we saw it emerging very strongly in the papers that we pulled out from the study that we are conducting, is aneurysms occurring within a group of patients at the same time, intracranially and extracranially. What that means is there any difference during the evolutionary process of humans where the development of an embryo to a human during the process of vessel wall formation makes a difference in the aneurysm wall within the cranial vasculature, or there is similarities that we can find interesting findings without the extracranial aneurysms. Would that make a difference in the scientific community if we were to study aneurysms? Absolutely, yes. Very often we are challenged by the difficulties of us to reach an aneurysm wall and to understand its formation, its structure, its biological structure. But if we were to study these aneurysms extracranially, where access to disease is easier, we can identify paths to the disease process that can help us in the near future not only identify genes of interest, but molecules within the pathway that we can target and eventually treat the intracranial aneurysms and as well the extracranial ones. We wanted to map, we wanted to see where these genes are present, again, across different ethnic groups. What does that mean? Well, if we were to map it and see in the map, we see that these genes are different across ethnic groups in Finland, Netherlands, but as well across China and North America. These findings are not necessarily the end of the process. We are still to expect other collaborators and scientists across the globe to publish findings from their aneurysm studies in different countries and regions where data will be helpful to collect more information on other additional ethnic groups from across Europe or Asian continent or continental Australia, where we can identify genes of interest that are commonly involved in the mechanism and the pathways of aneurysms formation within the entire population. But we wanted to pool this data and create an epidemiological analysis, and what we did, which goes to say that there is a work of a team that helped us build this papers which are in the process of publication with a very prestigious journal is the epidemiology of aneurysms. What that is how we see the numbers in clinics before we do the basic research sciences. So in general, we see, or what the scientists see is a damaged wall of the vessel where the endothelium or the media layer or the outer layer of the wall of the aneurysms is involved in a pathological process where different biological mechanisms, which are controlled by a single mutation of a gene or multiple mutations whereby different genes are involved, helps the disease of the aneurysms develop, that is, the formation of aneurysm, the growth, and eventually the rupture. But in general, and we know this by studies conducted earlier, there are inherited disorders, and as I mentioned, familiar studies that now we know which are transmissible through usually an autosomal dominant path, or acquired risk factors that we know and we have identified in the past decades or so that are involved in the development of aneurysms. Can we cross these risk factors together and see which genes are again emerging on risk factors which are modifiable? For example, hypertension. We can treat hypertension, smoking, alcohol consumption, sedentary life, or estrogen deficiency. These are modifiable factors that we can interfere with in the process and the disease process of the aneurysms. Unfortunately, we cannot do that in the inherited disorders, or up to this point, because the advancement in the scientific process of making changes to a specific gene or segments of genes are possible now with the advances in the science. What we realized as we were going to cross the data with what we have already pulled is of the risk factors that are inherited and the studies that we conducted in the past, is there any common shared gene or group of genes? And we found only 7 of those from the data that we pulled. That doesn't necessarily mean that these are the ultimate number. No, it just means that the time that we conducted the research, which was back then in December of 2023, there were only 7 genes or studies that the cross-reference could be found on the epidemiological study of the disease process of the aneurysms. Now, as we collected all the data, we sat down again with Reddy, with a very good friend of mine that I mentioned earlier, and we were discussing of what the interest of these findings would be for the community of scientists, but as well as clinicians, the colleagues that we talk about when we present these works. We realized that a gene or a number of genes that are involved in the disease process of the aneurysm formation are not necessarily unique to this disease process. You would see those emerging or being factors involved in the development of other disease processes of humans. And usually these would be the groups of transmissible diseases through a genetic or inheritance mode. And then there is another pattern that emerged through the findings of our work, and what that is the rupture of the aneurysm is a different biological process from subarachnoid hemorrhage. What that means is there might be a rupture of a vessel without the presence of the aneurysm within the circle of Willis or the tributaries. At the same time, we have been, for a long period of time, using a cutoff measurement of the size of the aneurysm, either that being the width of the base or the size of the dome aneurysm, as a strong indicating factor that the aneurysm would rupture. That was no longer the case. And what does that mean clinically? we cannot identify through imaging, through DSA imaging or angio-MRIs, the aneurysm that would rupture. But we can tell for sure from the basic science studies that there are very small aneurysms from which biological tissue has been collected during surgical interventions, where we put a clip and then we exclude that from the circulation. But then we realized that this aneurysm hadn't already ruptured. But as we studied the pool of the genes that were involved in the disease process, where the aneurysms not just grows and develops, but as well ruptured, we realized that this aneurysm, irrelevant of this size, in the very near future would have ruptured. So the size is no longer a determinant factor of the rupture of the aneurysm. As clinicians, these are some drawings that I collected from Professor Lawton. He is the senior author in the group of papers that we are about to publish. We are challenged by these difficult cases. We are challenged by cases that we cannot manage through open vascular surgery or endovascular surgery. And there are always going to be these cases in every field in the medicine where we would say, okay, it's impossible to treat, or with the tools and the knowledge that we have at hand, we are not able to provide a good quality of care for our patient. But how about we use the knowledge that we are putting together from the basic science work to see what molecules involved in the disease process of the aneurysm growth can we target with other known biological drugs or new to invent in order for us to target these diseases in the near future by means of just a pill or a combination of drugs. Of course, there are going to be intense methods of using what we call a spray coating through endovascular procedure, whereby we can go through an endovascular route within the wall of the aneurysm, and instead of putting a stent or a web and then a coil within the aneurysm wall, we put a stent or a web, we go inside the aneurysm wall, and then we spray coat the aneurysm wall with a specific drug or a chemical component that will stop the disease process develop further, which is to say that the aneurysm will no longer grow and eventually have that aneurysm with time shrink. Challenging cases as this one that I happened to see in Japan, this is a double aneurysm. Professor Kato is a world-renowned vascular surgeon that I learned a lot during my time as a fellow. Are common cases in Japan. And we see this often here in Canada, where I trained, and back home now where I have returned as a staff physician in Albania. We can treat some of those, but unfortunately not always successfully. So our work, not as a clinician, but as a scientist, is, can we offer a different view in the disease process of aneurysms, whereby not because there is a failure of the armamentarium in treating aneurysms, but because now we have a new mechanism that we know that is involved in the disease process of the development of aneurysm as a disease, the growth and the rupture, that we can interfere with the process, and whereby we can stop it from developing further and treat the disease, and why not cure it? Well, what are the potentials for medical treatment? We do believe that we are very close. So there are several groups across the globe. I mentioned earlier that Dr. Radovanovic is leading a brilliant team of researchers. I was part of that team at the University of Toronto, along with Dr. Hugo Andrade-Berzade, another great neurosurgeon. There are other teams at Harvard. Dr. Christopher Kalla as well is doing the same work. Dr. Redi Rahmani at the University of Louisville, people that I know and I've collaborated with. Dr. Michael Lawton at the Barrow Neurological Institute, where they are creating banks of biological tissues from the aneurysms they treat, with the idea for them to conduct an interdisciplinary, international collaborative research work, whereby in the near future, we have the potential to medically treat intracranial aneurysms. And I think that would be potential very, very soon. Now, the work that I presented is a teamwork, and the team is a large team of medical students, undergraduates, physicians, and fellows and colleagues across the globe with whom I've collaborated in the past 2 years to put together a series of 6 papers that we will be soon publishing at a journal of high impact in the field of surgery. When it comes to how this work starts, I never forget my early steps, necessarily in science, but as well as a clinician. When I attended my first fellowship abroad back then, I was a resident in Albania, and I met Professor Kato. She told me how important it is to conduct research work. I never forget the hours she spent in the clinic, and then after the clinic with us, the fellows, she pushed us harder, she pushed us further to work on something that stayed with us. And I have this repeated year after year when we meet and we get together with our fellows. And it echoed and resonated back when I was at the Barrow Neurological Institute with Professor Lawton, and I never forget his saying, "The pen is mightier." What that means is writing down our thoughts and putting some scientific work behind the clinic is going to help the generations of students and residents coming and following to do better work in what we believe is going to be the future of neurosurgery for some of the diseases. Treatment, not necessarily surgery. The story began at this hospital that you see here on the left is the current building where I practice, where I do my clinical work. There's not so much research, but it all started back then when I was a fellow at Fujita, the original Fujita, when it all, the insights of the scientific work came to me through the mentoring of Professor Kato, and for that I'm always grateful, and I wanted to extend my gratitude to the work she has done across these many years with generations of fellows in the community of neurosurgery, not just the youngs and the youngsters, but as well the seniors, for them to stay close, part of the team, to a larger team across the globe that helping the science and the clinic of neurosurgery expand and open the doors to communities that did not have the opportunities that they have in Japan or other countries, just like me back home when I was in Albania. And for that, I wanted to thank you. That would be the end of the talk. I'm so grateful that I had the opportunity to share these few slides with you. Any questions you might have?
Yes, thank you, Aaron. Thank you very much. It's marvelous, exciting speech about the genetic of the aneurysm and also the learning and the training from our mentors. So thank you very much. And we have some discussers and modulators. And any question, please. And so shall we start from our discussers? And so the first, today we have 2 discussers. One is Dr. Shalom and another is Professor Kimla. So Dr. Shalom, are you here?
All right, okay. Thank you very much. You can hear me? Yes. Thank you very much.
Good.
Okay. Thank you very much, Erion. I think Professor Erion was such a lucid explanation of a complex polygenic architecture. I think you managed to make the data that you collected quite relevant to most of us. But I could see there's those areas which is still not being looked into, like part of where I come from, Southeast Asia.
That's true.
Yes, however, we see a lot of aneurysms, but ours mostly come ruptured. We don't pick them up pre-ruptured, so they're mostly ruptured. I just wanted to find out, when you were doing this gene study, did you find any relevance, like you said, it's related to age and hypertension, but did you find any relevance to hypercholesterolemia, like cholesterol, because that is also genetically related? Is there any relations to that? one. And the other question is, when you were doing the study, did you notice, like you said, now the size doesn't make a difference? Is there any reason for that? Is there any reason that you could actually tell us why you think the size is not relevant anymore? Because, a lot of us see patients with small aneurysms and sometimes we just follow them up. So is there something else we can do to actually, see the risk of rupture for them?
Sharon, it's a pleasure to meet with you, and please allow me, if I may call you Sharon.
Yeah, please do.
That's correct. We do not have data that's coming from the country that you practice, or for that matter, more countries. And it would be very interesting to see what the findings would be if we were to collect biological samples, for example, from your clinical work, and then from Australia, and then from Brazil and Argentina. I am 100% sure that there will be differences across the biological samples. Now, you mentioned the question is about hypercholesterolemia. That's correct. Yes. In regard with that, that's a modifiable risk factor, with the exception of two diseases in clinical medicine. When we have a gene that runs into the lipoproteins that control the binding of cholesterol in the blood circulation, that makes it unavailable for the receptors within the liver to collect it and take it out of the blood, but it stays in the circulation, deposit in various tissues, including the vessel wall. I don't want to stop into that because that's an inherited disorder, but let's make it a risk factor like hypercholesterolemia, which is becoming, I guess, not an endemic problem, but a pandemic problem. Yes. The problem is that in the disease process of the aneurysm formation, cholesterol interferes with mechanisms that make it for the smooth muscle to break easily. It interferes with the intercellular connection, which makes it for it to break, to loosen, but at the same time, the connections with the basal layer of a smooth muscle that create the endothelium, because it's a single cell. The basal layer, which connects with a strome of stem cells, breaks easily. That creates for a turbulence of flow that interferes with the wall of the vessel, which at that point is not an aneurysm yet. And I'm going to make a connection, so I'm going to leap. So if we were to understand that this modifiable risk factor, just like as smoking, the smoking interferes with mechanisms that are specifically related with calcium channel binders in the walls of the smooth muscles as well, whereby a smooth muscle will no longer contract during the changes of the blood pressure within the vessel wall, but have it loosen up. So instead of being a uniform structure that opens up and then constricts, you would see a bleb at a certain point. Usually the blebs create where the vessel's wall make turns. They change into a different segment, for example, M1 to M2, A1 to A2, or where there is a connection, because there the concentration of smooth muscle is less compared with the fibrous tissue, which normally would be present to make the curve, to make the change from a segment of a vessel to a different segment of a vessel. And that was a clinical finding that Dr. Rotten mentioned in his work, that you would never see in an aneurysm if no change in segment or a bifurcation. And it stayed with me. And on the other end, let's go to the size. I visited Dr. Ernest Niemi in his clinic back when he was practicing in Helsinki, and I remembered him mentioning over and over again how size was not important in his clinical practice. I had no knowledge back then on the disease process of aneurysms, and it stayed with me. But back then, if you would remember, we had the 7 millimeter size of aneurysm, and we would say the size of a 7 millimeter is a cutoff point where we would indicate treatment, either that be clipping or endovascular, and that's fantastic. We had something to refer, which is good. At every time during the knowledge gaining process, we are true to what we know at that point, but as we progress into learning new things, now we tell ourselves, hold on, the 7 millimeter size was true for some sort of aneurysms, but not for every kind of aneurysms. What that means is very simple. We have seen, not only in animal studies, but as well from biological samples that we collected from aneurysms with different sizes. So the aneurysms were clipped in humans, then we cut off the wall, the dome of aneurysms, and we studied the decomposition of the genes that we identified in these aneurysms were related to a disease process that makes these specific aneurysms, irrelevant of its size, vulnerable to rupture. And then we said, okay, hold on, the size is no longer a cutoff point in telling our patients that because you have a 7 millimeter aneurysm, we need to operate on you. It doesn't matter if we are going to put a clip or endovascular treatment. We have now new findings on basic science research that is telling us that if a certain group of genes, for example, I'm going to mention one, it's PPIL4, Dr. Gunnell from the Yale group identified that, is present, and you can identify this gene with a blood marker from just collecting blood in periphery. You should be 100% confident to tell your patient that if in the near future you develop an aneurysm and we diagnose you with aneurysm, unfortunately the chances of that aneurysm rupturing are very, very high, because this gene controls a mechanism in a specific pathway where the breaking of a muscle tissue, a smooth muscle, or the connection in between cells is highly potential. That is going to eventually lead in rupture. So that's why the size is no longer a mechanism, a cutoff point that we will tell our patient that be careful with this size. But now we tell our patients, if we have this and this and that gene, or just this molecule present, we have confidence that this aneurysm will rupture. And that is not only intracranially. We see abdominal aorta or ascending aorta that is within the same range of developing aneurysm and eventually rupturing. So my apologies. I better stop here, because then
okay.
I'll carry on with science.
I know.
Thanks.
Okay, thank you. And we due to the time limitation, let's invite Professor Kimura for the last question, and please answer it within 1 minute. Okay.
Can you hear me?
Yes.
Absolutely,
okay. Very good.
Thank you for my small voice. So thank you for a nice presentation, Professor Erion. It's an informative and very interesting lecture and presentation. So I learned a lot. So I treat usually cerebral aneurysm as an open vascular surgery, and I totally agree with your comment that even in a small aneurysm can rupture in the small stage. So size is not a cutoff point to regarding the rupture or unrupture. So, but I think that in the early stage of the aneurysm newborn, it may consist of the thin wall of the aneurysm and may cause the easy rupture even in the small stage. This is my small standpoint, my clinical standpoint, and but I think so. What morphological differences do these genetic abnormalities cause? So I just want to know about the genetic changes, why the cause to the morphological changes. So it made a key point to detect the aneurysm rupture or still an rupture in the future. We have to know about the key point of the morphological changes caused to the genetic resulted from the genetic abnormalities. Thank you.
Dr. Kimura, thanks. Yes, your comments and question make sense. You're right and you're correct. We do see in the clinic the same, and we experience the same. We share the same thoughts. There's a small aneurysms, but the wall is very thin, is going to rupture. Now, there are genes out there which interfere in the process of the aneurysm formation. But instead of making the aneurysm wall thinner, because they interfere with the collagen deposits, for example, Ehlers-Danlos syndrome, they make the wall grow bigger, but is thicker. The genes that are involved, again, make an aneurysm form, but because of the process, the biology of the process that they interfere, make the wall thicker. This is going to be a large, gigantic aneurysm, but is not going to rupture. On the other hand, if we were to see a different gene involved whereby in the formation of an aneurysm, but is no longer forming collagen tissue in the walls of aneurysm, but instead breaking down and loosening the interconnections between cells of endothelium, these aneurysms wall are going to be thinner. There is going to be less collagen deposit, thinner walls, smaller aneurysm size, which is going to rupture earlier. So just to make a gross explanation of how we see that and what we have, what information we have collected thus far in the genetics of aneurysm.
Thank you. We have to know the reason why the aneurysm rupture from the genetic point.
Yes.
Yes. It's a point.
Absolutely. Well,
thank you.
I think, and just one sentence I'll add, with the data that have been collected, in the very near future, we will be able to collect blood samples before the surgery, or in general, with random with populations that we see in the clinic, and we would say, the presence of this marker in the blood tells that there is a high intensity of the aneurysm development. The chances for it to grow are this or that, or for that to rupture are these of that. We know that for sure in the near future we'll be able to tell that to our
Yeah,
absolutely.
Thank you very much.
Thanks.
Yeah. Thank you.
Thank you.
Okay. Many thanks to our presentationer and our discussers, because we have a very long time for the first presentation. So let's move to the second one. And our second one is the presentation is from Professor Farha. And no time to introduce more. Please, Professor Farha, please start your presentation. Thank you.
Yeah. Thank you very much. I just want a big correction. I am only neurosurgery resident. As a neurosurgery resident, I am just giving a basic discussion about what is ultramicroneurosurgery, because still now I am learning. So it is a conventional microneurosurgery is defined the neurosurgery performed using an operating microscope and a special microsurgical instrument to treat brain, spinal cord, cranial and the spinal nerve pathologies while minimizing the damage to the normal tissue. And the terminology is used at first by Professor Yasargil. He is actually was working in Zurich in neuroanatomy lab, and that's how the term started using from 1967. So actually, in which operation we are using and what operations are actually used or similar to the terminology of ultramicroneurosurgery. When it is high flow or low flow intracranial bypass or aneurysma clipping, or when we are opening a skull-based tumor resection such as cavernous sinus meningioma or microvascular decompression. In such operation, we are using the ultramicroneurosurgery. Also, the keyhole microneurosurgery procedure, it is which are the approaches like supraorbital, retrosigmoid, or lateral suboccipital keyhole approaches. There are also the techniques where we are using the microneurosurgery techniques. So these are just an image reflection that where we are using like clipping and also with the aneurysma, and why actually it is important. Like before we were using big craniotomy, and we are also operating the patient, and then why it is come ultra micro, why these two terminology importance and why it is helping to us. So on the neurosurgical point, it is more clearer visualization with the help of microscope, and also the using of the submillimetric instrument and very precise training, including breathing, motor, cognitive training, help us not to damage the normal parenchyma, and that's how we can save more, which was not possible before the era when it was not using ultramicroneurosurgery. In such a reason that we are not hampering or involving the normal brain parenchyma. That's how we can also reduce the risk of the injury, also the local inflammation. When we do any surgery, we create a local inflammation that produce local accumulation of the fluid and edema, and also the post-operative complication that is also reduced by using the microneurosurgery. And also parallel to that is when we injured less, then coming back to the normal hemostasis is very easy for us. So patient recovery was very quick in this sense. And in terms of oncology or vascular efficiency is also the, it gives us the maximal safe resection, because as we are damaging less, and also by using the ultra micro neurosurgical instrument, we can achieve the targeted structure and even less damaging to the surrounding neurovascular structure. And it is only possible, how I just said, that it needs a very long-term training to achieve on that precision level. As I say, when we damage less, then it is also help the patient recovery. It shorten the hospital stay, and also early mobilization is also quick in this position. And we also save more cranial nerves and also the brain stem structure. And it also help the easy recovery from hearing, swallowing, or facial movement. So actually what we use for ultramicroneurosurgery, it is definitely the optical instrument that include the high magnification, and it's include microscope and endoscope and exoscope. So these are the technical things what we improve, and parallel to that, our outcome of the surgery is also improved. So even the retractor, the microneurosurgical retractor, self-retaining retractor or endoscopic holder, just very precise minimal change can give us a very good effect on our surgical field. Also the microdissection and the handling instrument, that means like bayonet microforceps, we are now like the highest technological innovation era. And that's how we are using straight angle and angle also in different angles, ultrafine dissector, tumor debulking, and also the micro scissor is also, it is even now become personalized, that how much curve up, curve down, which angle should be there. Very fine blades are using now nowadays, which is just giving us the highest edges and highest precision of the ultraneurosurgery. And it's also include definitely the vascular part of the brain, which is more critical, and aneurysm and AVM clipper, how will be the shaft of the clip and the jaws, how will be the pressure of the grips, also the microneedle holders, how it will be angle. These all are helping us only to get the more precision result in our operative field. Also the bipolar forceps, ultrafine tips, microsuction, cannula, every instrument is helping us to get the highest precision. Also parallel to that is ultrasound aspirator like CUSA. We use also for debulking of the tumor. Also ultrasonic bone scalpel, like the highest drill, high speed micro drill. It can be long bar, slim bar, to reach also to do the mini craniotomy, and also with the help of diamond beads like petrous part or clivial part. This is giving us a tremendous fine works in the ultramicroneurosurgery. There is a special instrument for CPA angle tumor removal, and also the transsphenoidal or endoscopic skull-based instrument. So this is now become like, it's no alternative, but it's become more personalized in terms of which operation we are approaching and which fine and more precise personalized instrument we are using to get the better outcome. So this data actually will represent that how is for last 10 years what we are achieving by doing the ultramicroneurosurgery. So it's reduced operative trauma, lower the complication rate, shorter hospital stay, and good long-term control. Like it says that it is shown that in aneurysma series, it's improved clip placement, and the reduce of the complication rate is around 6%. So it's a big number in terms of progress. It's not only the instrument, also there are a new technology like robotic micro or super micro surgery, which is also taking place parallel to that. So it is not only the precision of the instrument what we are using. So there is also involvement of the newer technology or external instrumentation, and that is super microneurosurgery or the robotic neurosurgery. So by using those, we are lowering the time per anastomosis, the tremor reduction of, because we are still motoric function, and so it's like tremor reduction, and also the motion metric, and that's how we are also reducing our error score. And these all are now is from the drilling to the opening of the cranium can be now controlled by the robots. So it's like suture drilling, everything can be now is done by the ultramicro instrumentation. So thank you very much to listen from my side. As I said that I am very thankful for the opportunity, and I also meet with Professor Kato once in my life in Bangladesh when she was in WFNS Congress, and I also meet with Professor Sami, and that's how my life even changed, that I am coming from Bangladesh and now I'm working in a neurosurgical resident in Germany. It's all because of the help from Professor Kato and Professor Sami and ACNS and WFNS that which help us to coming from the lower economical country and to work and to learn more and to contribute to the neurosurgery. So thank you very much to listening to me and to help me to contribute also to ACNS. Thank you very much.
So thank you so much. So any comments from Sharon?
Maybe I'll let Professor Kimura. Do you have any comments?
Thank you very much.
Yeah, let me go first, yeah.
Okay, Sharon, do you first want to? Okay.
No, I mean, I think, thank you very much, Farha. That was a very concise presentation of, I think, advanced technology. So maybe presently or currently in the world, maybe less than 10% of us might be actually using this technology. And of course, it still is very new. So I think it's, we need a bit more before we can make our conclusions. I mean, I'm always welcoming new technology, but I think we always need to take it with a pinch of salt. Yeah, maybe Professor Kimura, maybe you have something to say.
Okay, thank you, Dr. Farha, nice presentation. So first of all, I just want to say to you, congratulations, you are given a chance to work on the first in Bantane and next to the first in the Germany with Dr. Sami, right? Yeah, very nice for you to enjoy your neurosurgical life. Yeah, congratulations. And you talked about, you summarized your importance of the techniques in the neurosurgical microneurosurgery, super microneurosurgery. Very important point you mentioned about it. And so of course, we have to learn first about the anatomy of the neurosurgical structures. And after that, we have to learn about the actual techniques, meticulous techniques, how to perform the safe and actual procedure. So I think, as I mentioned, most important point is the hemostasis in the actual surgery. Of course, less invasive. Of course, the minimum exposure or something like that. Another point is very important, of course, as well. But the most important is the hemostasis in the So in the precise to perform the precise microneurosurgery, before we have to achieve the accurate hemostasis in the appropriately within surgical field. And so I hope you will learn various important techniques in your residency. Yes, and I just want to see next time your surgical procedure in a video on the on your academic meeting. Thank you. Thank you for your presentation. Thank you very much.
So, Professor Kimura, thank you very much. I also invite Professor Cherian because he already worked with Ultramicroneurosurgery and my journey also started with him. So maybe Professor Cherian can also elaborate a little bit.
Farha, thank you, Professor Kato. I learned high-level neurosurgery when I went to Japan with Professor Kato and Professor Sano. They remain always my teachers. Ultramicroneurosurgery is a term that we started when we got the exoscope and started operating things under over 40 mag. And maybe if there is time, I can show, Farha told about the videos, but I can, of course, if there is 5 minutes, I can, of course, show these videos. I have these videos. So anybody who wants, they can write to me, or if there is time in this meeting, we can show. There is no problem. But it is always, as Kimura said, it is operating under the highest magnification, with highest skill sets, with exoscopes. And presently, I've been elected as the chair for the WFNS Innovation Committee. So we are going ahead with exoscopes, more magnification. We are looking at 100 plus magnifications endoscopes which are completely different, which are with robotic holders, VR, AR, and AI and machine vision to help us. So neurosurgery still happens to be very primitive compared to most of even gaming. If you compare to gaming, even neurosurgery is so primitive with the tools that we still use. So we hope to change it. And I suppose ultramicroneurosurgery is a step towards that.
Dr. Nice to see you again here. So long time no see. Yes, I know. I understand your activities under WFNS, and I know you recently your interest shifted to the exoscope using in actual usually surgery. I usually in Japan I exoscope we have the OVI Olympus commercially available of exoscope, and yes, I agree with your comment. And we use if we use the exoscope in the highly magnified, so wide, so big monitor surgical field we can see, and so under that highly magnified inspection using the 4K 3D images, we can perform more easily, more accurately perform the super micro neurosurgery. So yes, there's maybe the future neurosurgery will be shifted to the exoscope. Yes, I agree with your comment. And next time, I just want to see your surgery. 5-minute video. Thank you. Thank you.
So maybe the last question from Biswas.
Thank you, Sensei. It's a very outstanding topic, Sensei, ultramicroneurosurgery. I have a couple of questions. What is the considered absolute tool for ultramicroneurosurgery? It's number one. And number two is rigor. And last question, Sensei, do you have experience of cerebral bypass under exoscope? Thank you.
Okay, yes, we do all our bypasses under the exoscope. That is exactly what I wanted to show, but I guess there is no time right now.
Yes.
But sometime I'd be happy to show our bypasses. We do it at zooms of 60 plus and at 0.6 millimeter vessels. And as Kimura said, with absolutely no blood in the field.
Thank you so much, Professor Erion. So for the sake of the time, shall I invite our last speaker, Professor Yang, to share about his topic.
And today is my honor to have a presentation, 5 minutes, talking about the ethic and the scientific about neurosurgery. It's not a question about skill or techniques. And I only make 3 slides for this presentation. Let me share it. Hardworking and patient care. That's my the question to myself. So today I have the opportunity to discuss with dear audience and my great thankfulness to Professor Kato give me the opportunity to have the question discussed, and would like to hear from you and for your opinions. What is hardworking? Because we are neurosurgeons, when we graduate from medical school, when we training as a residency, we have a long time of residency, because only 1 or 2 years training is not necessary for neurosurgeons. And we have at least 4 years. In some departments, they may be 5 or 6 years, and including 1 year of chief residency. So we have long time of residency compared to other specialists of the medical science. And if we are a neurosurgeon and start our travel on neurosurgery, we have a long time on duty and a long time operation. I can remember that when I was a young neurosurgeon and when I was in my residency, the longest operation in my department in Tianjin is about 30 hours. 2 groups of neurosurgeons operated for the neurosurgery for the patients. That was the year in 1990s. Maybe there are some difficult and maybe some undeveloped of the neurosurgery instrument and the skill of surgery under microscopy, but the long-time surgery is basically requirement for neurosurgeons. Forget the time of surgery is a basic requirement for me. And today I would like to discuss this question with dear colleagues and our young neurosurgeons. What's your opinions when you're on the table for the patient? And if need time, what's your attitude? What's your opinion? We consider the time or we consider the patient? The first question is that for our young neurosurgeons. And the second question is that we are a lifelong on call. Even I think even Professor Kato is a world famous and the best neurosurgeon in Japan. If there something happened in her department and require her attendance on the patients, I think she will come to the department and see the patient without hesitation. So that is very, very hardworking and even lifelong time. And I think that even when we choose the occupation for our life, we are neurosurgeon. When we want to be a neurosurgeon, we all hardworking people. And for example, I have when I was met two residents from Seattle. They are white people, and they graduated from very good medical school, and they recruited by the residency of United States systems. And I asked them, you are very intelligent people, and your high school performance, and when you study universities, you should be very smart people, and your MCAT may be very high. And at the same time, when you thinking that your classmates maybe study in financial, in law school, in medical, in business school, when after graduate, you are residency, you are training for 7 or 5 years for residency with very low salaries, but your classmates went to Wall Street, they are big money they made. What's your consideration about that situation? These two American residency, they consider it in several seconds and give me their answers. They said, it's a call. It's a call from heart. So that's my I'm very agree with them. It's a call from bottom of our hearts. We need to take care of our patients. People help people. People take care of people. So we can working together. So what is the patient care? To my opinion, is the patient first and the patient benefit first. So everything we have done in the clinical, we need to consider the patient first. For example, never forget the idea. When we are talking about something, we are make a schedule for operation, we never forget patient first. So, and second, we need training. Why we need training? After training, or in the procedure of trainings, we can do what we know how to do for the patient. Because if I'm not a neurosurgeon, I'm a pediatric, I'm a physician, I'm an ENT surgery doctors. We cannot perform operations for neurosurgery patients, neurosurgical patients, because we don't know the procedure, we don't know disease, we don't know patients. So even we are neurosurgeons, we need to know what we can do for patients. We have the limitations. If we are across the limitation, we try to do something new or try to make a hero of ourselves. That should be forbidden. We need training, we need study for the acknowledgement what we can do for patients. And the second way, we need to do right surgery for patients. That means the surgery is coming from experience of a lot of our pioneers. Our teacher, our mentors, they have do a lot of operation. They have treated so many patients. We should learn from them, and I should learn from their summaries about the patient, what we can do for them. So we cannot cross the second line, is that we cannot try anything new, and our mentors haven't done. But techniques and ideas developed forever. So that's renovation. We need renovation. We need new therapies for patients, but I have a method. That is my last suggestion for young neurosurgeons. We can perform clinical research, and we can collaborate with each other to find new methods for patients. For example, we can find some new treatments for new techniques for the patients, but it must be under the ethical and scientific procedures. So please remember that ethic and scientific, it is our basic. People should take care of people, and we can gradually reduce our risk and for the patient, and we can find a new way for our patients. So that's my little bit of suggestion to my heart, and for all of the young neurosurgeons, and please have consideration. Thank you. Thank you so much.
Yes, thank you, Professor Yang. Really good work.
Okay, thank you.
How we take care of people. So with that comment, so shall I invite some short comments from Sharon and also Kimura?
All right. Thank you so much, Prof. I think you've said it very well. You've actually precisely put what it needs to become a neurosurgeon. Actually, for the young neurosurgeons, I think it is not an easy pathway when you choose to become a neurosurgeon. What Prof. Yang has said is all true. So I think everyone out there knows this is what is needed. Only thing is asked of the younger generation, because you seem, I don't know, sometimes I'm a bit jealous of the younger generation. I do not know if you are like that, Prof. Yang, but I seem to see they seem to be able to enjoy their life a bit more than we used to. I mean, I never had much of a life when I was training, honestly, no life at all. Even today, I think I don't have much life, because like what you said, you think of your patients first. So even when you're at home, sometimes even when you're showering, you're thinking of your patient, or you're thinking of your surgery, and you're doing a post-mortem of how you can do it better. But that's because I think our life is, our passion is neurosurgery, or maybe that's our first love. But I think what we must remember is also we need to prioritize. So one of the things in your life as you get older, please learn how to prioritize your life. All right, because I know some of us become very obsessed, and it can help. And like what Prof. Yang said, you search for the wrong things, income, things like that. Becoming a neurosurgeon, please don't be falsified. It's long hour surgery. and actually don't think so much for the income. I think that is something you must remember. Do it because you love it, right? And you'll never be tired.
Yes, you are right. I very agree with you every consideration because I grew up from young neurosurgeon too. I'm also studying from the older generations, and I don't think I have the power to summarize all the right things for grown up for young neurosurgeon. And my recommendation is that, and for when you make your choice, that's your lifelong destination. There's no time for retirement. You can retirement. You can have a retire, and you can retire, but never think about this because you accumulate for a very long time from your patients, from your colleagues, from your mentors, and from your teachers. You accumulate so many experience. Don't keep it for yourself. It's for public. We need to share it with the next generation and the next. So that's my idea to my heart. I would like to share and I would like to show my operations. I would like to give my comments and my suggestions for every case, and even for the basic research. And I hope we can get more powerful young neurosurgeons. I hope we can get more acknowledgement of the neurosurgery and for the disease for our patients, so we can take care of them very, very good. But we can get a good result. So because I'm in the middle age, because even for myself, I'm not too I don't think I have the power to make such a summarize. So Dr. Ben, could we invite Professor Kato give us some comments as her students? We would like to listen to her.
Yes. Please, Professor Kato, please make your remark to summarize Professor Yang's viewpoint.
So before me, maybe I want to ask Dr. Farha. Farha, is everything good for you now?
Okay. Salamu alaikum. Konnichiwa.
Konbawa.
Konbawa. Thank you. Thank you. It's very excellent and good webinar, and with advanced technology, and we used and also learned a lot from you, and also proud from Farha Anjum, Dr. Farha Anjum. That's and congratulations for achievement. And we would like to also our young neurosurgeon, especially women in neurosurgery, learn from Farha Anjum as well, and with under supervision of Professor Kato. Thank you very much.
Maybe Kimura-sensei want to say something for Dr. Yang's lecture.
Oh, thank you for giving me a chance to talk to Dr. Professor Yang. So I totally agree. Thank you for your Dr. Yang. I totally agree with your presentation, your opinion that we have to do the surgery for the patient first, of course, needless to say. But we have to work so long time. So we have to, as you mentioned in your presentation, I also grown up as a neurosurgeon under the old style of the Japanese neurosurgical scene. The operation time is so long, and we're 24 hours on call, 7 days a week, and so hard to keep as a neurosurgeon in my younger era. But now in the changing in the neurosurgical field in Japan also, I think in your country also, younger generation love to shorter surgical time, and daily surgery sometimes. So we have to show that less invasive short-time surgery. I just want to share my younger generation that how we do the less invasive short surgical and operating time to give the best outcome for the patient. We need to elaborate on this matter. We as a expert neurosurgeon. So thank you for your comment. I totally agree with your comment. We have to keep our motivation. We have to keep our passion and keep our integrity for the patient. Yes. Thank you.
Thanks. Thank you, Sensei. So,
thank you.
Yes. So the Erion's the talk is very, very important, I think. So now is pre-operative examination or maybe some research work. It's very, very important, such as sometimes in Japan or China, that we have so many unruptured cases so far now.
Yeah.
So I think many of them maybe with those research or pre-operative examination tell us no need to treat. We can maybe select cases, I think. Thank you very much for such a nice presentation. And also the Farha, thank you very much from Germany. I think that you are very lucky because so many good teachers, such as Dr. Sami. So it's very good chance for you. And also the now that I think you are as a young neurosurgeon now, you should learn more and the skill and the knowledge about surgery and dedication for the patient. And also, Dr. Yan, thank you very much for your long-lasting and experiences. I think now in Japan, is work-life balance is very, very important word. I think we cannot force the young doctors to work.
Yeah.
More than 7-8 hours, I think. There is some limitation. So, like as I said, talked more and more less invasive. So, the endovascular treatment is done the open surgery. So, I think now is a paradigm of the treatment of the neurosurgical procedure, I think. Well, I think it's a good word. It's a good word now, I think. So thank you very much for the nice webinar and also the two good commentators. Sharon, thanks.
Yeah. Thank you. Thank you.
Yes,
thank
please.
you, Professor.
Thanks.
Tonight we have exciting webinars and online. So these two presentations give our insights very deeply. So the ACNS and maybe in the future WNS can join ours. The ACNS will be the example for the world. We have the thankfulness to Professor Kato. Without her organization, we cannot join together. So thank you very much, Sensei. Thank you very much.
Thank you. Thank you so much.
Okay. Thank you. Thank you. So,
Dr.
Ben, okay, Dr. Ben, and I think today our webinars may be to the end of time. Please have your words and announce the endness of our webinars, please.
Thank you so much. So yes, and thank you so much. It comes to the end of our today's ACNS webinar. I would like to thank you, our chair, Professor Yang, for his great contribution today and also yesterday, and for being the chair of our webinars. And I would also like to thank our speakers today, and Professor Erion, and also Dr. Farha, and also our discussant today, Sharon, and also Kimura Sensei, and also alongside with all the audiences with us. And then without further delay, I would like to say a big thanks to all of you for joining today, and I hope you enjoy our ACNS webinars. And today is truly educational, and we have some in-depth sharing of neurosurgeons' perspective, not only on the neurosurgery but also the life of the neurosurgeon. So with that, we conclude our webinars, and then it's time to say goodbye to all of us. Bye bye.